Welcome back to another episode of ACR On Air, the official podcast of the American College of Rheumatology. I'm your host, Dr. John Hausman. Today, we're diving into a fascinating and often overlooked topic in rheumatology: complications from diabetes that mimic rheumatic diseases. We'll start by exploring diabetic myonecrosis, a very painful muscle disease, and then we'll shift gears to discuss scleroderma, a skin-thickening disorder that can resemble systemic sclerosis, but which has very different underlying mechanisms. I'm joined today by Dr. Elena Schiopu. She's an expert in scleroderma and myositis. Along the way, Dr. Schiopu shares invaluable insights on how to approach complex rheumatology consults in the hospital, the importance of thoughtful diagnostic reasoning, and why sometimes the best medicine is simply avoiding unnecessary tests and treatments. Dr. Schiopu is the Director of Clinical Trials for the Division of Rheumatology in the Medical College of Georgia of Augusta University. She graduated from the University of Medicine and Pharmacy in Romania and did her medical training at Robert Wood Johnson and Wayne State University. She was the director of the myositis program at the University of Michigan and was involved in several critical trials in myositis, including the famous RIM trial, as well as in developing outcome measures in scleroderma. She's an advisory member of the Scleroderma Foundation and the Myositis Association. As you'll notice during this interview, she's a great medical educator, and she provides insights not only about diabetic myonecrosis and scleroderma, but also about the practice of medicine. Enjoy. Elena, welcome to the show.
Nice to meet you and nice to be on the show.
So we're going to talk about some cool and interesting topics today, which are rheumatology disease mimics, and especially things that happen to, we'll start with people with diabetes. One of the ones I wanted to talk about a little bit more is diabetic myonecrosis. This is a serious complication of patients that have diabetes. But, I remember learning briefly about it as part of my fellowship, but I don't really know much about it. Can you help us to understand what it is and how it presents?
So the nomenclature, the names of some of these conditions could be sometimes slightly misleading, but in this case, the word diabetic obviously relates it to it. And the word myonecrosis suggests a little bit of death of the muscle fibers. But as far as how this condition was recognized and how it came about, it's a little bit rare. So it's one of those conditions that don't necessarily happen on a regular basis. So it has to be sort of periodically reminded or placed back into a rheumatologist and any practitioner's mind so we don't miss it when it happens.
Great thing that we're talking about it today.
Exactly. I've always feel diabetes deserves its own maybe triple specialty. It's such a complex disease and it affects so many facets of the pathophysiological sort of pathways there that it's very hard to pinpoint one single mechanism of this myonecrosis. And it's, again, bringing to mind this collagen too. And we're going to talk about a few other diabetic rheumatological mimics in diabetes. And I always laugh when my colleagues and trainees who aren't yet differentiated into rheumatology fellows that nobody really cares about joints, specifically collagen, and nobody cares about the scarring process, specifically fibrosis, until you realize how important those joints and then the collagen are day by day life. And when you lose joints and when the collagen decides to go a little nuts and start, causing this fibrosis. So going back to the diabetic myonecrosis, there are not a lot of cases out there. And again, because I probably only saw one or two cases in my 2-decade career. Don't tell anyone I said that. Every time I think about it, or I kind of hop on the PubMed and I kind of quickly look around to see what else has it been published, how many other cases are out there. And there are not that many, right? We're looking only on a couple of hundred cases published. You could look at lifetime rheumatologists and they might tell you they could count them on a hand. But that bears the question, do we really think about it? Are we missing a lot of it? So I was the myositis director, and I'm building a new program here at Augusta University. So I screen a lot of referrals for myositis. And then on the inpatient side, when we do consults, there's the consult, hey, this patient has a swollen thigh, and I don't know, John, what's your experience at your hospital, but somehow, sometimes I feel we're the first consult to come by the hospital bed. Did you notice that? Like they should actually call ID and HEMONC.
All the time, especially for those patients with patient has fever, rule out, I don't know,
Right.
Still's disease. I'm like, wait a minute. Yeah, get IT on board first. Much more common.
And then the second should be HEMONC, but they're always busy, right?
Right.
Or always the first ones, which is, as I'm getting kind of more senior in my specialty, I'm less frustrated with that. As a fellow, I could see how I get frustrated. Yet another consult, what's going on? But I get actually excited. We get to be internist all over again. And internal medicine is so beautiful, and general rheumatology is so beautiful. So, yeah, we get to tell them, hey, you need to rule out first a clot. You need to rule out a infectious process. And that's what happens in diabetic myonecrosis. It's a bit misleading because it comes on very strong and it looks like the thigh, it's a very regional muscle problem, usually kind of targets the thigh muscle. It could happen. I've seen some case reports also in the calf muscle as well. It usually doesn't cross sides, but again, case reports are always interesting. You could see it bilaterally as well, but it goes after a big bulk of muscle, which is something like the quadriceps group. And it's extremely painful, hot, sometimes hard, indurated, we call it. So usually my first and second sort of differentials would be something like a blood clot. And then the next one would be some sort of an infectious process. And it's obviously not something you miss. You will get consulted on that because the patient hurts. So it's interesting how we go about looking at the muscle. In general, some inflammatory muscle disease is one of the more difficult things to rule in because it's more a little bit of a puzzle game, an elimination game in that area. So the biggest clue, it's always the diabetes. So it's a patient who has had diabetes for a long time with A1C that probably exceeds 10, so a little bit of poor control of the A1C. And I always go back to the endothelium. I think a lot of the answers in rheumatology lie in one of the biggest organ that we have, which is the cardiovascular, right? The blood vessels, and the inner layer does a lot of things to our body. So I think diabetes is particularly heavy on damaging the endothelium and the microvasculature. And it's kind of like affecting these blood vessels, I believe, in the bigger, bulkier muscles.
So as you mentioned, it sounds like it presents in these big muscles, usually the thigh, sometimes the calf. Unilateral or bilateral?
So based on my experience and what I've read, it's usually unilateral. It doesn't cross right the midline. But again, there's been case reports in both thighs as well. But that's not the case. It's rare. And if it would happen, it would be rather the exception. And obviously would make us go down other differential diagnosis trees.
Got it. And I love it that you're already discussing, in a patient with like diabetes and a swollen leg or whatever, not go running to the diagnosis of diabetic myonecrosis and thinking broadly about other maybe more common causes like blood clots and infections. So what sort of workup would help us in making the diagnosis of diabetic myonecrosis in a diabetic patient that presents with a swollen, painful thigh, for instance?
So, just like we talk about differential diagnosis first thoughts, I think there's a sort of rule out other conditions portion of the workup. And then it's the rule in, which is, okay, now that we know those are not the issues, we could focus on what we think goes on. And it's hard sometimes. It's easier as I get older, but it's very hard not to go for the first thought. And I don't know, seeing the generation of fellows where we're having our first year fellows now are very rare bird TAFRO. I call them the TAFRO fellows, right? Everything is TAFRO until proven otherwise. I'm like, that's 1 in 60 million. Let's look at other things first. How about sepsis? Okay. How about other, other issues? So going back to the rollout, obviously kind of doing the basic workup of a CBC. Let's look at the muscle enzymes, which will be a little bit elevated, but not crazy, looking at the left shifts and things for infection. But then specific for the muscle, the some sort of an image would be necessary. Obviously, if we're in the process of ruling clots out, someone should do probably some sort of a venous duplex. Obviously, clots in the thigh is extremely rare. Usually they happen more in the calf, but it's not a bad thought. Ideally, and we're hoping to get a little more streamlined or that we'll get an MRI, and ideally we'll get an MRI of both thighs, so the unaffected and the affected. So then there's a nice comparison. And That's why I talk to fellows about being pristine and precise and very specific in their consults and differentials, because the second you put that in the chart, in the visible medical record, the second you put that, oh, this is absolutely this, then every single radiologist, other consultant, you're smiling, so I know you feel my pain, will take that and will run with it to death. And every radiologist would say, definitely that. I had definitely Bechet's, on an MRI of the brain, definitely Bechet's brain. I'm like, teach me. I don't know how Bechet's brain looks like, but because we entertain it, the radiologist will, put that in there. Now you have another problem. So we have to be very careful with the original broad consults that we put in there. And of course, talking to irritated fellows about consults and all that is never a good thing, but we have to find a way to explain our power. I tell them we're like super. I don't know how you feel, John, but I always feel like the super doctor, right? Or the people who get the immune system, the endothelial system. We're system people. We're system doctors. We look at the full picture. We look at hands, and I look at feet. No matter how difficult that might be, we look at a lot of different things. So I'm sorry, I'm going a bit on a tangent here, but in the original evaluation, I try my best not to put the full consultation quite yet in. You know how it is. You get the consult, you tell them first the recommendations, the recs. You give the recs to the primary team and you tell them, hey, consult this, that. You get the pushback. I do the attending to attending. They do it. And then we say, hey, try to get the MRI. Let's try to look at them and keep an open mind. Don't jump to the diagnosis yet. So you don't bias the radiologist. There's still a lot of gray in the muscle imaging, right? So musculoskeletal radiology is growing really fast, but it's not quite a well-defined craft, so to speak. So we don't have very good, especially in the muscle MRI, we don't quite yet have very good guidelines. But in general, it's kind of hard to miss an inflammatory process, but MRIs are sensitive, right? So you could see the white, the water, the MRI imaging of that suggests that there's muscle myositis, there's muscle inflammation. And it's going to be hyperintensity, right? More of the white kind of images. And the impression that I'm getting is it could affect one or two bellies of the quadriceps. It doesn't have to be all of them, but it's more localized than the, typical idiopathic inflammatory myopathies. And of course, if you have the contralateral thigh that doesn't have those findings, then you start ruling out this is not idiopathic myopathy. This is not, other forms of myositis that tend to be more systemic. And we could start narrowing it down to the diabetes. Of course, that A1C helps dramatically because typically a well-controlled diabetes patient, and I don't think there are that many out there, unfortunately, the diabetes is a tough disease, would also rule out diabetic muscle issue.
Yeah. I mean, I love the fact that you're not only so knowledgeable about these conditions, but how thoughtful you are in sort of the evaluation of these patients and that you're verbalizing out loud how you think about it and how, we and fellows should think about, the consult, like how to approach consults in the hospital. And I think it's so thoughtful because, yeah, we see it all the time where, especially in the electronic medical records, where things get copied from, one note to the next. You put it in your differential and now it becomes the diagnosis and everybody else refers to it as, that's the diagnosis.
And I think we did a little study where when I was at Michigan, one of the fellows actually looked at the likelihood of over testing patients with a label of lupus, right? So they get way more CTs, they get way more blood work. And it's very, labels matter. And I usually try to, for the 2-year duration of the fellowship programs, I always tell fellows, you're no longer, an internist. You're no longer just you and the patient. Right now, you're a consultant. You're going to be a teacher for the rest of your life. Your consults need to be sent to somebody. They're going to be read by many individuals, by many other specialists, and you represent basically. And once they go into the inpatient consult, I tell them we sometimes are the custodians of that patient's both workup and treatment and what's going to happen. Yeah, we're not the primary team, but we are such an essential portion of that approach. And everybody will read our consult. We hope, right? So sometimes our consult doesn't get read, but that's a major way of communication these days, right? People don't pick up the phone anymore, but everybody reads everybody's note. And these patients are complex and likely to have other comorbidities from diabetes. So they're fragile. We can't miss. We have to be very precise when we diagnose the diabetic myonecrosis. Diabetic myonecrosis oftenly missed or misdiagnosed. It's a rare condition. Usually it happens in patients who have had diabetes for a while with relatively poor control. Tends to be unilateral in targeting the large muscles like the thigh muscle. Very acute, painful, explosive onset with features of inflammation and edema on the MRI, but also if indeed patients get the biopsy of the muscle, some evidence of necrosis of the muscle. I personally try to avoid biopsies in this type of acute inflammatory and exquisitely tender myopathies because the effects of the biopsies could be exacerbating the condition itself. And I'm very proud of the amazing effort that put together the 2017, the idiopathic inflammatory myopathy classification criteria, which don't have much to do with this, but they actually have now 2 columns. And they're tedious. You need a calculator and all that. But there's a column with biopsy and a column without biopsy. Because I honestly feel bad to take out tissue from a patient who needs that tissue. And yeah, muscle you could grow it back sometimes, but not when you have myopathy. So I don't necessarily think biopsies are the best pathway for diagnosis. If we could get access to an MRI and rule out other conditions, I think that's gentler for the patient as well.
Got it. Is there a role for sometimes we think about EMGs?
It depends a lot on the proficiency of the electromyographer. We do have neuromuscular neurology, and they tend to be the best trained neurologists. I believe that it will look like any irritative myopathy, but at least it will be very patchy. It would only be in that area. So at least we could say, okay, this is not symmetrical proximal like a idiopathic one, like an IIM.
Great. So it sounds like first we rule out other potential conditions that can cause similar findings, and then we get the MRI and we suspect the diabetic myonecrosis in a patient with poorly controlled diabetes. How do we think about, do we have any idea what's causing the muscle death, and therefore what we should do to try to prevent that from happening and treat the patient's acute pain?
So there's obviously, when a disease is so rare, there's always multiple valid hypotheses, right? It's always the case. But I think the most plausible pathway is, again, the endothelial pathway. I do believe that patients have tortured blood vessels. And just like myonecrosis is saying it, I think there's some deficient blood supply to a certain area of the muscle. And also, clinically, this acute pain with kind of this inflammatory reaction almost makes me feel of ischemic pain, when there's the body screams when there's lack of blood supply. Obviously, on the biopsy, the necrotic fibers also support that hypothesis. And, there's a possibility of some blood clotting also contributing to the ischemia. I don't think there are that many pathology or biopsy sort of studies because of the rarity of the condition to prove that hypothesis.
And any potential triggers? Are these patients that are outside, living their lives and then come in with a painful thigh, or are these, complications in patients that are admitted to the hospital with other things and then they develop this in the hospital? And any ideas of triggers?
Yeah, I think the majority of cases that I've noticed, the major trigger is the poorly controlled diabetes, but diabetes doesn't flare, right? So it's that's the background. I think the most of the cases I've seen are inpatient based. They usually get admitted for that. They don't develop them after. So I didn't find a common thread there, like, for example, excessive physical effort or being outside and getting dehydrated. But I think everything is possible, right? And that's the other thing, when we look at these patients as rheumatologists, we always keep in the back of our mind other rheumatic conditions that could be affected, could be involving muscle inflammation. And another thing is usually antibodies, if we actually get to order them, are usually negative. I practice a little bit half and half, like British versus US medicine, in which I don't just want to order all the antibodies all the time. I kind of want to do it a little more specific with pre-test, probability. In other words, if the review of system points towards a specific autoimmune disorder, we could look. But I don't know if it's worth sending the full biomarker, for example, which is a few $1,000s for this clinical picture.
Right. I guess the unilateral nature would make an inflammatory myopathy very unlikely.
Yeah, the only myopathy that would be so asymmetrical, but they would lack the acuteness would be something like inclusion body myositis. But again, that one has its own particular features that are so clinically evident, in my opinion, that it's definitely not acute and inflammatory, but rather smoldering and atrophying type of myositis.
Got it. So having made the diagnosis, how should we treat these patients? Immunosuppression, supportive care? How do we manage the pain?
Pretty much. So I think I don't know what you've experienced at your hospital system, but being in two different academic systems, everybody and their cousin wants to give prednisone. And the only
Yes, yes.
reason to consult us is to prescribe that salmeterol, give us it's okay. And oftentimes they start it before we even get there. So it's a big fight. I tell fellows, this is a no prednisone kind of month for us where we're going to fight that the best that we can. And it's not, it's the same. It was the same at University of Michigan. It's the same here. It's always the blast away, get rheumatology, blast away. Anyway, so we have to be careful, right? We're dealing with diabetic patients who have poorly controlled diabetes, so steroids are a bad idea. I'm not one to shy away completely from steroids. I think a short term might be good. But if you think about the nature of the process, I think inflammation is an epiphenomenon after the necrosis. It's not as much of a driving phenomenon. So to some extent, prednisone might make it a little bit worse. As far as circulation, it just kind of changes the laminar flow and it could make ischemia worse. And again, increase those sugars, you know how challenging that could be. So the supportive treatment is to try to manage the pain the best that we can. Patients will have comorbidities, kidneys, everything else. Pain is a very difficult symptom to treat. I prefer, again, I'm going to say this often, but the older I get, the more I prefer non-drug interventions. So I avoid drugs as much as possible due to the many side effects and kind of cold compresses, elevating the leg, trying to avoid strenuous exercise of any sort, just taking it easy for a while. And again, as far as the inflammatory process, everybody jumps on NSAIDs. We got to be careful a little bit of the kidney function and the diabetes and, again, the vasculature, the laminar flow there, because NSAIDs could be as damaging as the prednisone when it comes to that. So also very important to not baby that muscle forever and keep it going. So gentle exercise, gentle movement is necessary because pain will limit the patients, right? The time of recovery varies a little bit and it could be weeks to months. So majority of patients, we usually see it like within 1 to 2 months that it eases off, probably a little bit sooner. I tend to not give too many restrictions to the patients even after they leave the hospital. I tell them to continue a normal life, try to move around and try to walk and do all their life activities so they don't lose muscle function and general functionality.
And then try to get them improved glycemic control to prevent this from happening again.
That's one of the big issues. And the other issue is the recurrence. So it does tend to, kind of like everything else in medicine, once it happens once, it does tend to come back. So I think it's a good time to reinforce that glycemic control and exercise and everything else so we could avoid future events. Patients don't want to be in pain again like that.
That makes a lot of sense. Certainly, that's an incentive for better glycemic control. If you don't have it, then that thing's going to happen again. Great. That was a great overview of diabetic myonecrosis. And as you mentioned, certainly rare, but important to think about and consider when we're evaluating patients in the hospital. I want to switch gears a little bit to another disease I know very little about, which is scleroderma. And this seems to be also a complication that can sometimes happen in patients with diabetes. Can you talk a little bit about it and how to distinguish it between, the obvious mimicker is this systemic sclerosis or scleroderma?
Yes, and that's interesting topic because it's not scleroderma, it's scleroderma. So it's a little bit different than the systemic form. It's been a while since I've seen a case, but I think it's more common than the diabetic myonecrosis, but it's still something that could start subtly and be missed. So to this day, I always feel the cape. I feel the upper back skin of any patient that I initially evaluate, just kind of looking for that kind of hardening feel that scleroderma could cause. So this is where the collagen kind of comes into play and the balance between too much collagen, and how much exact collagen is never as important as in this disease. The relationship between diabetes and this abnormal sort of collagen thickening is still, I think, a little bit blurry. We still don't know exactly how it happens, but just like the myonecrosis, we again see it in poorly controlled. I would venture to say I've seen it more in obese patients too. So maybe obesity, inflammation from there plays a role, and longstanding diabetes. So patients who have had it for quite some time. And the rarity of the disease, again, is not as common, kind of makes it amenable. Every time there's a rare condition, you find a million subclassifications, one more complex than another. Did you notice that? It's insane. Other scleroderma mimics have that situation too. I think maybe even more in pediatric rheumatology conditions than in the adult ones. But going back to the type that we're talking about mostly in diabetes is this type 3, they call it, which is not viral or it's not related to a paraproteinemia. But we still have to consider all the other potential reasons for scleroderma.
Right. So you mentioned viruses and paraproteinemia. So thinking about getting the SPAP for these patients.
Exactly. And kind of making sure they're up to date with the primary malignancy screenings, just in case, just for good measure there. And obviously the diabetes control. I always almost say that when a patient doesn't know what their last A1C was, that they probably aren't very well controlled to begin with, right? So they're not seeing them. So usually it starts in the upper back area, so starting from the lower neck area on the cape area, we call it, like the Superman cape, and it's very symmetrical, very waxed, very young looking skin in a way. No wrinkling there. And then it kind of goes down from there. It could go up on the upper arms. I've seen it on the abdomen, lower back, and it could kind of creep up the face as well, the neck and the face. It's hard for me to say if there are predictors for progression. I guess the diabetes control is key, and if not brought back into range, into good control, the skin thickening, the scleroderma sort of continues extending. So I've seen it basically from the sides of the face all the way down to the
Wow.
waist area.
And so when you touch the skin, it just feels sort of hard, like in a patient with systemic sclerosis, or what can you describe a little bit more, like what you're seeing sort of around the cape area and around the face? Is it swollen?
It's not swollen. It's not puckering. It's basically immobile. It's impossible to wrinkle. You can't really make a fold of the skin. It is similar to some extent to the systemic sclerosis skin, but it's a lot deeper. You could almost feel like the deeper dermis is involved. In scleroderma, there is some tethering, but eventually also systemic sclerosis softens up. So you could actually kind of have a mix of a little harder skin and skin that's starting to loosen up a little bit. But in scleroderma, it's very immovable. It's
Got it.
So if I have the blindfold and I felt systemic sclerosis upper back versus and many patients with systemic sclerosis don't have their upper back affected. The chest and the abdomen might, but not the upper back. So this kind of cape distribution is very unique to scleroderma. Although it's waxy looking, I don't recall seeing it in an African American, like a darker pigment patient, but it doesn't usually affect the pigment the way systemic sclerosis does. Systemic sclerosis does, cause it darker when it's inflamed, in the early inflammatory stages of the skin tightness, and then a little bit lighter, and then pigment could be irreversibly lost in the late fibrotic stage. But scleroderma doesn't quite affect the pigment, so there might be some other pathophysiological explanations for that. And it's, if you dare to biopsy, which, again, I'm not a big fan of biopsying a very hard area of the skin because it's hard to heal that area and hard to make it, approximate after the incision. And you should do like a deep tissue biopsy if you're going to do one. The findings are exquisite thickening of the dermis, basically the collagen and the skin on the bottom. And yeah, there is a direct correlation with the diabetes there. So some sort of communication occurs in there to cause this thickening.
Amazing. So the diagnosis is pretty much based clinically on sort of the thickening in the typical areas, like you said, the cape area in a patient with poorly controlled diabetes. You mentioned, the challenges of biopsy. Is there any role for imaging?
There's been some efforts to advance ultrasound a bit in skin. I think if you were to do a MRI, ultrasound is still in the US, at least it's still way behind MRI. I think there would be visible skin edema. I don't think many patients get to do the MRI because the MRI is, they're so localized. You got to pick an organ, right? You can't just do, hey, do an MRI of the skin. You can't do that. So you have to kind of do that area. But yeah, I think the ultrasound will detect that thickened dermis. The MRI will show the skin edema and the thickening. And then I'm trying to remember, we had some devices we used to do in scleroderma, some durometers or whatever, trying to kind of measure the skin elasticity. Luckily, they never caught on because they're awful. And but we don't really have good imaging or standardized findings for this complication. But the other big thing is, again, just like the myonecrosis, is to rule out other scleroderma mimics, which there are quite a few. There's eosinophilic fasciitis, and again, we could talk in peau d'orange and the furrowing there, and then also more of a forearm distribution. We're talking, there's a form called generalized subcutaneous morphia, extremely rare, scleroderma mimics. You don't see that many of them, just maybe on a handful, single-digit patients. And then obviously systemic sclerosis, which comes with Raynaud's and dysphagia and telangiectasias and many other subtle or not so subtle things that scleroderma patients might not have. Lots of diabetic patients. I've been growing very observant and very careful with the vegetative nervous system. So diabetes does target the vegetative nervous system, which is plays a big role in thermoregulation. So a lot of diabetics might look a little bit like they have livedo reticularis. They might look a little bit like they have a bit of extreme temperature sensitivity. So they might look a little bit Raynaud's-y, a little bit blue. Yeah, it's all part of that whole autonomic dysfunction, right? The thermoregulation. But the systemic sclerosis secondary Raynaud's is pure vascular. So a lot of it is very well sharply demarcated. And obviously they help now for capillary changes. But all of those subtle things need to be looked at carefully.
And does scleroderma affect the hands and feet like scleroderma does?
Right. So it's the reverse distribution, right? And scleroderma, it starts centrally. So I think it's centripetally, right? And then in systemic sclerosis, just like you said, the skin gets involved at the fingers and then comes back up or down, depending on where you start, toes or fingers, and it progresses centrally.
Fascinating. And what is the time course when people start developing these features? I imagine it's not immediate, but is it weeks to months that they start developing the skin thickening?
Yeah, it takes months. And usually 10, 15 years of living with diabetes.
Got it.
I think obesity is an additional risk factors in there. But then again, obesity also makes the diabetes a little bit more difficult to treat. And then it continues on and on for months. And I think, again, I would need more hard data before I pronounce myself with this. But I do believe that there's periods where it kind of progresses a little bit more and then plateaus for a while and then progresses a little bit more. But I personally never saw reversal. So once it happens, it's very difficult to, much like systemic sclerosis to some extent, it's difficult to bring it back. Now, systemic sclerosis spontaneously, right, remits. So it gets into that late fibrotic stage where skin kind of technically thins out in there.
And what is the impact of this skin thickening in patients with scleroderma? Like you have some thicker skin in the back. Does that play a role in how they feel and the activities that they're able to do?
From what I'm reading and based on my patients, they never really feel that thickenings. So if they close their eyes, they couldn't tell. It's not itchy, it's not burning. I mean, I guess it could be, but majority of patients don't feel it that way. Where it affects them a great deal is it could be so profound that it creates restriction in the arms or shoulder movement, which is very, very critical, even in breathing, right? So shortness of breath, inability to expand the lungs. And in time, it just kind of becomes like a large cast, basically, all the way, especially when it affects the back and the abdomen. So one of the discussions we have in clinic is stretch the skin as much as possible. No physical therapist knows how to exercise the skin, right? And the stretching of the skin, but patients know, to do as much stretching as possible. I think that's important to re-teach the skin to stay a little bit more elastic there. But the biggest thing is there a role? And that's always been my question. Obviously, there's no randomized controlled trials or efforts to look into that, but is there a role for immunomodulators for us to intervene and try to sort of either slow down, curtail, derail some of this progression? So that's where I guess there's more questions than we have answers. I've tried, the basic DMARDs like methotrexate. I think I even used some mycophenolate mofetil like we do in scleroderma. I anecdotally saw zero response. Patients, they get the placebo, they feel, oh, maybe a little bit better, but we don't really have a good instrument for it too, right? We don't have an outcome measure. You could attempt to do like a modified run a skin score, but it's not adapted for scleroderma. So I always tell fellows, anyone who wants to listen, it's hard to look at treatment efficacy when you don't know exactly, when you don't have a good instrument to measure that change, that's sensitive to change.
Yeah, and I can imagine it. I mean, if you have like collagen deposition within the dermis, like how to take that out or prevent, right? Like the therapeutic interventions to sort of reverse that are like very difficult. Like I don't know how that could even be done.
I remember, I think it was in 2014 when the first antifibrotic, in theory, drugs were approved for IPF. There was OFEV and Esbriet, or both nintedanib and Esbriet are both approved for idiopathic pulmonary fibrosis. And that was a big year for me, like the year my last kid left the diapers behind, but I was so excited because I thought, oh my God, this whole slew of fibrotic conditions, you say collagen, you take fibrosis, all this stuff is going to be fixed. I don't know if I'm still as enthusiastic because nothing much changed from there. Yeah, IPF now has options, which is great, but I thought they're going to extrapolate the use of some of those antifibrotics for other conditions like that. But I think our biggest barrier, and we always think mechanistically, right? You want to think a pathway, like which cell got upset, which cytokines started going. And now we have all these wonderful tools, very specific, blockers and enhancers and agonists or whatever. So what can I use? What's the most likely mechanism so I could block it? And you can't escape the fact that this is an epiphenomenon of long-standing diabetes. So something upset that collagen. And also, you can't quite quantify, well, how much inflammation do I have to work with? How much? Because, if there's still inflammation, then we have some reversible course there versus, okay, now we got this collagen body that's thickened. What do we do with it? Can we affect it in any way? So I forgot to say, obviously, we get the SPEP, like you mentioned, SPEP, UPEP, we get the total protein. We look a little bit at the blood work, make sure these patients don't have a MGUS or other paraproteinemia. We make sure they're up to date with their cancers. We rule out systemic sclerosis the best that we can. Again, everybody practices a little differently. Now we have the ability to get specific antibodies. So we could get the scleroderma-specific antibodies. I always tell fellows, you own everything you order. So if you get a false positive, SCL70s tend to be super false positive, then you own that. Then you're going to have to explain it to everybody. So it's not always so algorithmic, right? So we want to use that index of suspicion or pretest probability before ordering those. I don't know. Is that something that you've noticed in your both training and then as an educator? Are you doing the same thing? Are you trying to push a little bit the pretest probability? Or
Yeah, and I had one of my mentors during my fellowship was very cautious about ordering blood work and autoantibodies, and I sort of go that way. I mean, just yesterday we had a patient. I was working with a resident who presented with subjective muscle weakness. And, the question was to send the myositis antibody panel. I said, the exam wasn't really consistent with an inflammatory myopathy. And, why don't we start with the basics? I sort of conceded to let's do a CK,
Yep.
but, maybe not sending the whole myositis panel for this patient. So I do think I'm judicious about the use of autoantibodies.
I love that you say that because there's a bit of an age difference between us. And sometimes I feel we get so carried away. And there are moments like on Tuesday, I saw a young African-American patient with a EF of 15%. And he had the vest. And after he dropped his EF from, normal 2 years ago to 15, they finally consulted us and he was covered neck to toes, literally in this red rash. And he's had a negative ANA. Some other rheumatologists touched him in the past. I think it was low positive homogeneous, so 1 to 40 or something like that. So here I was kind of trying to figure out, okay, what do I order? So there are cases in which you want to be a bit broader and be like, okay, let's think of all the rheumatic diseases. I honestly think he had some sort of an eosinophilic syndrome, and his head-to-toe rash that he's had since he was a kid was probably the most terrible eczema that I've ever seen. So, but there's no eosinophils on the periphery. I'm like, I don't trust eosinophils. They're very bad actors. Anyway, going back to our area, it's an art. I think that's why I love being a rheumatologist, because it's an art, not a 1, 2, 3. And being judicious and being careful with everything that we order, I think, is important as well. So going back to the management, I've done the DMARDs. I've also tried good old IVIG. I've been doing that with all the challenges and approval and everything. And, these patients do have diabetes, so I don't see there's any role of steroids in any way, shape, or form for this type of conditions. And I can't say that I've been wowed by any of these treatments, but part of the observation is also that it's hard for me to measure this disease that doesn't necessarily operates in flare and remission. We don't have a good outcome measure to kind of show improvement versus worsening, aside from just the sheer progression of the scleroderma affecting more areas. And sometimes the more I look at some of our diseases that are more fibrotic and tedious but ongoing, I feel like we might need to settle for failure to worsen than for improvement. So you're not going to get them better, kind of like in scleroderma, but at least keep them from getting worse, which is a very valid outcome measure in there.
Yeah, I guess control their hyperglycemia, and then hopefully you can halt progression of this condition.
And it's insane because if you look at how much of the US population has diabetes or prediabetes, I think we're over 50% right now, right? Well, over half of the Americans have diabetes. So probably in the rest of the world to some extent too. So there is something in the water, right? I'm smiling all the time when I say that. There's something in our environment that we need to dramatically change. We need to make some significant changes there.
Yeah, I couldn't agree more. And as you mentioned, these sort of musculoskeletal complications of diabetes are just going to become more and more common if there are.
As the prevalence of diabetes, right? And, I do teach and show residents, fellows, the chiroarthropathy. I know that's a big mimic there. And I don't know what your experience has been, but I feel like it's often missed by the primary care teams. They don't necessarily think chiroarthropathy. I don't know why. It's very that they think rheumatoid arthritis before chiroarthropathy all the time. So we do get quite a few patients with those in clinic as well.
Yeah, for a minute, do you want to talk a little bit about how you make that distinction of the diabetic chiroarthropathy from rheumatoid or other inflammatory arthritis?
I don't even know, to be honest with you, why inflammation even comes to mind, because the deformity is due to inflammatory symmetrical polyarthritis, like rheumatoid arthritis. Even the position of the hands would be different, and it's, at least at the beginning, very reducible. MCPs are affected and they're swollen. With chiroarthropathy, it's more of I would call it a deformity. They just simply can't hyperextend the PIPs anymore, and it's more of a fibrotic. Again, I blame the collagen on that one as well issue than it is a inflammation. So they're not reducible anymore. The prayer sign is very important. If anything, I would want to differentiate it from something like diffuse scleroderma, the claw hand of scleroderma. But even the chiroarthropathy has a distinct feature as well, with the PIP more involved than the rest, and could be also a tendon issue, kind of like the Dupuytren contracture, where the flexor tendons of the palmar, the fingers, get affected. And unfortunately, again, we're back to the diabetes control, occupational therapy, not a whole lot of immune modulation that could get us anywhere there.
Yeah, Elena, this has been a wonderful conversation about, various musculoskeletal complications of diabetes and rheumatology mimics. And I think, it's worth thinking about these conditions, the diabetic myonecrosis and scleroderma, when we have, as you mentioned, patients with poorly controlled diabetes presenting with things that on the surface may look like rheumatic diseases, but when you explore them a little bit further, you've mentioned there's clear features of these conditions that are actually quite different from inflammatory myopathies and scleroderma.
I think the rheumatologists play a huge role in sort of helping out, and we're very available. We hope to get better at being even more accessible than we've been so far to diabetologists, primary care physicians, endocrinologists, and we're very available, very happy to help out. I'd rather be able to say this is a diabetic musculoskeletal mimic than have the patient started on the wrong medication and the wrong immunosuppressant, right? We're always good custodians of our craft here.
Great, and I also love your insights about how to approach consults and how to approach patients in clinic, and the use of all these room panels being sent for our patients.
It's carefully and judiciously. I usually kind of get a little bit snotty about it. I should be more humble, but you have the career path of clinician educator. And I'm like, say what? I don't have that path, but I educate every day. Everything I do, I educate my nurse, my MA, even my clinical research coordinator. I show her the difference between SSA and SSB. I educate I breathe education. That's what you do. And once you're a consultant. So anyway, sorry, I know there's a defined path of clinician educator, but we're all doing it all the time and we'll never stop. So I really love listening to your voice. And I have to confess, I haven't been a regular visitor of the ACR podcast, but you, John, convinced me. And this would be now a regular. I'm assuming I have to download an app, right? On my
If you have an iPhone, the app is already downloaded.
okay, there you
it's
go.
called
Easy.
Podcast.
It's called,
We make it easy. But Elena, thank you so much for your time and for your really valuable insights. As I mentioned, not only about these, rare diseases, but about sort of the process of rheumatology and how to approach patients and consults, how to approach diagnostic tests. It's very insightful. So I really appreciate your time.
Thank you so much.
And I'm glad that we picked up one more listener to our podcast.
I know, and I'm going to spread the word. I'm actually going to talk to my division here, make sure that it's a regular. I'll probably be surprised. They'll all be like, "Well, you didn't know about this? We've been listening to it."
I hope that's the case.
That's going to be the case.
Thank you, Elena. Have a great day.
You too.
Well, there you have it. Now you know everything there is to know about diabetic myonecrosis and scleroderma. As Dr. Schiopu emphasized, careful clinical reasoning and a broad differential are the key to avoiding misdiagnoses and ensuring that patients receive the right care. And of course, as with so many things in medicine, prevention through better glycemic control remains a critical piece of the puzzle. Thank you all for listening, downloading, subscribing to our show, and for rating us with 5 stars or however many stars you think we deserve. You can find our show notes for this and all other episodes at acronair.org, Apple Podcast, Spotify, and on your favorite podcast app. Until next time, keep those sugars under control. And as always, stay healthy.